hand button and the reactions that you have available to yourself. There are two different ones. Your hand will pop up on your screen next to your name if you're raising your hand, but really we're looking for those reaction emojis that just float across to the screen. And we are at the top of the hour, so we're going to go ahead and get started here. I see we've got quite a few attendees. I'm excited to see you all here today. Thank you so much for being here and welcome to the Medicaid Spring Sustainability Actions Training. My name is Carly, and this information today is getting presented by the trainers from Healthcare Policy and Financing. This is part one of a two-part training series. So make sure that you do come to both parts. Today, we're doing an afternoon part one session. Please remember that this is a webinar, so your video and your audio are automatically disabled. This training is being recorded, and we will be having it available to you after the conclusion of all of our training sessions. We'll now go ahead and disable our chat box, but you will have the opportunity to utilize the Q&A after our first few slides of our session. You'll be able to put some questions in that Q&A box. It's located at the bottom of your screen. It's a small box with a question mark. If you see someone else's question and it's similar to yours, you can upvote the question instead of re-asking it in the Q&A. Your questions in the Q&A may not be answered right away, as the answers may be covered during parts of the training later on. Please try to listen to the training before asking questions. And don't worry if we're not able to get you your answer today. We will be working to provide out an updated FAQ document after the conclusion of all of our training sessions. There will be resource links that are put into the chat throughout the meeting, and all of those resources that we would be noting in the chat are also going to be listed on our resources slide near the end of this presentation. We will be hosting optional office hours in the following weeks, and these office hours are specifically for you as case managers to come with questions from this training, and we encourage you to register for those sessions as needed. If you don't have the registration link, you should reach out to your case management agency training leadership to get that. Again, we will be recording, and these training slides will be posted at the conclusion of the training series on the LTSS training webpage. In alignment with our mission statement that you can see on the screen, these sustainability actions are geared towards a standard equitable assessment for all ages and populations of members. We're very excited for this process to get up and running and to be able to share with you, as case managers, your roles and responsibilities within it. We'll get started by reviewing the agenda for today's training presentation. In today's session, we will be covering a lot of material. Don't worry, you'll have an operational guide, and some of you may have already received that from your case management leadership to go along with this training. We'll be covering the background of why these actions are occurring and the timeline for you as case managers to take action, depending on when your member's certification period is. We'll cover details about the new caps for personal care, homemaker, HMA, legally responsible persons, community connector, IRSS, and the exceptions process. We'll also look at the notice of action requirements. We'll leave you with key steps and tools and resources to help you along the way. In our second session, we will be covering additional information, diving deeper into how you can utilize age-appropriate guidelines, the new direct care service calculator, task standards, and HMA documentation requirements. This will help ensure effective authorization of services for all members. After today's session, you should leave feeling confident about the timeline for taking action steps. Be able to identify which services are subject to the new caps and exceptions process, and when and which notice of action to send. Again, you'll have tools and resources to take with you. I'd like to thank you all again for being here with us today. It is so important to understand why these changes are needed. Before we get into the details of the policy and changes, I want to start by naming something directly. This is a heavy topic. Anytime that we talk about reductions or tighter controls, it can feel personal, and it is. These decisions affect real people, members, families, caregivers, providers, and communities. So I really want to acknowledge that up front. If you're coming into this training with a little bit of concern, frustration, trepidation, uncertainty, you are not alone. At the same time, it's important that we're clear about the purpose of these changes. The core reason is simple, even if the situation is complex. We have to make these changes because we need to have protection of the long-term sustainability of Medicaid long-term services and supports in Colorado, so that services can remain available not just this year, but 5 years, 10 years, and 20 years from now. Colorado's Medicaid budget is under intense pressure. And after this year's significant reduction, and its essential driver of that pressure is long-term services and supports. LTSS costs are growing faster than state revenue due to rising enrollment, increased service intensity, and a higher cost of care. And without action, this growth is not sustainable. While LTSS serves only about 5% of the Medicaid members, it accounts for roughly 42% of total Medicaid spending, whereas the remaining 95% of members account for 56% of spending. That's not a criticism of LTSS. It's a reflection of the reality that these services are intensive, they're specialized, and they're essential for people to live safely in their homes and their communities. But because LTSS is such a large portion of spending, it also carries a significant share of the responsibility to ensure the system is growing at a rate that we can sustain. We are seeing more children enrolling in waiver programs, and once enrolled, they're using significantly more services than in the past. These trends reflect real and complex needs, but without thoughtful policy changes, they also drive cost growth that outpaces available funds. Colorado is one of the fastest aging states in the nation, and more people with complex health care needs are living longer than ever before. That demographic shift means that the demand for LTSS will continue to grow, making it essential that we act now to ensure that the system can support future generations. Workforce shortages and increasing wages have significantly raised the cost of delivering care. So now we're in the position of needing to adjust our policies to align with these rising costs. Case management work matters here. Even when the what is constrained by fiscal reality, we still have meaningful influence on the how. Your expertise, what work you do every day with your members, directly affects whether these changes can succeed in a way that's responsible. As we go through this training today, I invite you to keep two things in mind. This work is about sustainability and long-term access, not just short-term savings. Your work is critical to implementing these changes in a way that is thoughtful, fair, and as minimally disruptive to our members as possible. With that foundation, let's walk through some of the solutions and support for what's changing, what it means operationally, and how we can support consistent implementation. Because of these cost drivers, HCPF is implementing several components for solutions and support. HCPF is implementing caps on personal care, homemaker, health maintenance activities, and community connector services. Case managers will be utilizing age-appropriate guidelines and documentation during their level of care screen. They'll be utilizing the new direct care service calculator for justification and documentation of service authorizations for personal care, homemaker, and HMA. You'll utilize the HMA documentation checklist, guidelines and checklist for members, and the case managers will utilize the task standards for effective authorization of services. All of these things together are going to ensure that we can maintain the availability of these services across populations, ensure cost savings and effective authorization of services. We'll be covering these items across both sessions of trainings. And now I know you're all thinking, thank you, but when will this start? What do we have to do and when do we have to do it? We're going to go over the timeline on the next few slides. This chart is an example timeline with a 2-month lead time. We know that some of you may be working 3 months ahead of schedule and not 2, and even some cases you might be a little behind and working 1 month prior to somebody's certification end date, but this is an example. There are 2 primary dates that I want you to keep in mind and remember. The first date is April 1st. This is when the first changes need to be effective and the cost savings that we've discussed must begin. So these changes begin with members that have effective start dates of April 1st and forward. The second date to remember is November 30th. That's when all of our sustainability actions must be fully in effect. First, let's talk about members whose continued stay reviews fall between now, with an April 1st effective date, and September of 2026. For those members, the changes can be made during their regularly scheduled continued stay review, and they'll become effective 4/1 or later. This will work for all of those members whose continued stay reviews happen before September 30th, right? Those September 30th CSRs are going to have effective dates in November. You may already have completed a few of your cases that have April 1st start dates. We are 2 weeks into January, so that is reasonable. You may have already done that. Don't worry, we're not asking you to immediately go back and change any of the cases that you've already completed. Those members will be captured in our second timeline of actions to be taken. For those members whose continued stay review is regularly scheduled to happen after September 30th, we need to make these changes ahead of time and before November 30th. So in this case, the changes will need to be made during the member's regularly scheduled monitoring visit. This is how we will make them effective prior to the November 30th deadline. If a change is made at a monitoring visit, it must be effective 60 days after your visit. A primary difference with these cases is that you will be completing a service plan revision and subsequent PAR changes, but you're not being asked to complete a new level of care screen during your monitoring. You'll have other tasks to complete depending on the outcome. When you're doing service plan revisions for these reductions, there can be a need for the service to be prorated for the remainder of the certification period. We'll talk a little bit about proration later in the training, and it's something that you should already be familiar with. Remember, not every member on your caseload will be impacted by these changes, but some members may be impacted by multiple. The caps are applicable to cases with 4/1 dates and forward. And while the task standards became effective in December, so for intakes and any cases with start dates prior to 4/1, you're already using these task standards and you can issue your reductions, denials, and authorizations accordingly. For intake, you're still basing it on those task standards and they'll fall into the group of having revisions at their next monitoring. So with that of our timeline, we're going to go into more details about the first set of caps. These are for personal care, homemaker, and health maintenance activities. This chart shows you a high-level display of the caps for these 3 services. It has the annual limits and how that translates into approximate daily hours. This is just the first chart. We have a few more charts to show you throughout the training that are going to get into increasingly more detail for you to be able to utilize during this process. We'll discuss each of these limits in the following section. The first service that we're going to talk about today is personal care. We'll be providing some reminder definitions for each of these services, but you should be familiar with them already. Personal care services are a covered benefit to members that are enrolled in Community First Choice. These services are designed to help your members with daily tasks that they're unable to do. Think for a second, What are some of the tasks included in personal care? You don't need to type it in, just think. All right, if you were thinking tasks like personal hygiene, eating, transferring, position, bathing, dressing, you are correct. All of these tasks on the screen are part of personal care. Services can also include an attendant going with a member to the store while they're having some personal tasks that need to be done, and appointment management to help with personal care services during that. Protective oversight for certain supervision needs is also included in personal care, and we're going to spend a little bit of time on protective oversight today. Protective oversight. Recently, you probably saw some memos come out about this, but the reason we're reviewing protective oversight is because we do have a more defined definition, and it also has a new limit. Protective oversight means providing active line of sight supervision that requires immediate intervention to prevent harm. This is when a member's disability, memory, or cognitive functioning related behaviors or impairments place that member or others or property at risk. Protective oversight does not include and cannot include restrictive practices unless you have a documented rights modification in place prior to the provision of services. Remember, protective oversight is only a personal care task, and it cannot be authorized as health maintenance activities. Protective oversight, again, within personal care, it's not in addition to, but it's a task within personal care. It includes intervention timing, that includes, but is not limited to, verbal redirection, blocking access to hazards, removing dangerous items, or hands-on guidance. Protective oversight shall only be approved when there is a documented evidence of risks requiring regular and predictable intervention within the last year. The member's service plan must include the frequency, scope, and duration of intervention required. Protective oversight cannot be authorized for purposes of companionship, childcare, general supervision, reassurance, emergency or crisis intervention, or routine monitoring that is not necessary to address the disability-related safety risk. Remember, protective oversight alone cannot be the sole reason for the visit or services. For children under age 18, protective oversight may be authorized only when the level of supervision required intervention is substantially greater than what is typical for a child of the same age without disabilities. Protective oversight, again, for children cannot be authorized for routine childcare, typical parental monitoring, or supervision that is age appropriate and expected for children of the same age. I'll give you a potential example for children under 18. A 12-year-old child with an intellectual and developmental disability and epilepsy is engaging in frequent self-injurious behaviors like headbanging. This is triggered by sensory overload. These behaviors occur daily and require immediate intervention to prevent injury. An 11-year-old child with significant emotional and cognitive impairments has frequent, unpredictable, aggressive outbursts that include hitting, biting, and throwing objects at others. Line of sight supervision is required to intervene quickly and prevent harm to the child, to their siblings, or any of their caregivers around them. These examples are for when protective oversight might be authorized for a member, but it is never in lieu of other necessary behavioral services or other supports. That takes us to our new limits. The annual limit on personal care is now 10,000 units per annual service plan year, which translates to about 6.5 hours a day. The new limit for protective oversight that's within personal care is 7 hours per week. Exceptions to these will be covered later in the training, but I do want to remind you that if you authorize acquisition, maintenance, and enhancement of skills for this service, you must be indicating it as such in the bridge and have a corresponding goal for the AME in the care plan and service plan. Quick interactive question for you here. See if you're still with me. 20 minutes in, we've got a child who's 10 years old. They're unable to determine water temperature. They're unable to safely transition in and out of the bathtub, and they're unable to reach their lower extremities. As a case manager, which service would you authorize? You can find your emojis at the bottom of your screen. Click the emoji that best represents your answer here. All right, I'm seeing a mix here of whales and turtles. The correct answer, personal care bathing. Thank you guys for participating. We're going to be doing that throughout each of these sections, so keep those emojis handy. Homemaker services are next. Homemaker services are general household activities that are provided in the home for an eligible member to maintain a healthy and safe home environment. Think for a second, what are some of the tasks that are included in Homemaker? All right, if you were thinking tasks like routine house cleaning, vacuuming, cleaning bathrooms, cleaning the kitchen, cleaning bedrooms, you are correct. We've got a lot of different tasks that are included in Homemaker. Remember, Homemaker services have to be completed within the permanent living space, except for acquisition, maintenance, enhancement of skills, laundry, and shopping. This service has to be authorized for the benefit of the member and not for the benefit of other persons living in the space. When we talk about homemaking services, we also need to remember the availability of a service called extraordinary cleaning. This is a benefit that is available to members on the Supported Living Services waiver and the Children's Extensive Support waiver as of July 1st, 2025. Extraordinary cleaning services are specialized cleaning, disinfection, and sanitation services that are necessary to ensure a safe, hygienic living environment and prevent the spread of infectious diseases or pathogens. Extraordinary cleaning includes the use of common commercial grade products, infection control protocols, handling and disposing of biohazard materials, and specialized materials or equipment. Extraordinary cleaning is maxed at 700 units or project total, approximately 3.4 hours a week. Enhanced Homemaker, which was previously available through the SLS and CES waivers, and extraordinary cleaning services are distinctly different services. A previously approved authorization for Enhanced Homemaker does not automatically mean that you should see a request or ask for authorization of extraordinary cleaning. Most tasks that were performed under Enhanced Homemaker should now actually be performed with CFC Homemaker and/or acquisition, maintenance, and enhancement of skills. Remember, with the implementation of Community First Choice, Enhanced Homemaker will be entirely discontinued on 6/30/2026, and it should not be authorized on PARs with start dates of 7/1/2025 or later. Again, extraordinary cleaning tasks are beyond routine homemaking tasks, and they're necessary to ensure that safe living environment. Extraordinary cleaning tasks may include things like cleaning the floors and other household services using commercial grade equipment, laundering and disinfecting members' towels, bedding, beds that are soiled with blood and other bodily fluids, air duct cleaning that might be essential for the health and safety of a member that mitigates their disability-related health complications. This list is not all-inclusive, and other tasks may be permitted as appropriate. Extraordinary cleaning services cannot include personal care services, homemaker services, any services that the member can do independently, services that are deemed typical parental responsibilities, or services that do not follow age-appropriate guidelines. It also cannot include any services that are provided in uncertified congregate facilities. You have to always make sure that services are going to meet the task definition of extraordinary cleaning services. Let's practice a little bit more. If a member requires support with preparing meals, cleaning the kitchen after meal preparation, and taking out the trash, what would the appropriate service be? You can choose your emoji now. All right, wonderful. I see all of those whales swimming up our screen. That's correct. You would choose homemaker. These members' needs are more basic in nature, and they do not meet the definition of extraordinary cleaning. Next up, if a member has incontinence issues and needs help cleaning their mattress, what are the appropriate services here? Choose your emoji. All right, I'm seeing a mix of all, but I do see a lot of rabbits that are popping up on the screen, and the rabbit is the correct answer. This is actually an extraordinary cleaning task because we're talking about cleaning their mattress because of bodily fluids. Commercial grade equipment would be required to sanitize this mattress adequately to disinfect it. Again, this service is available in the SLS waiver for this member. They're 45, so they would be enrolled in SLS to access extraordinary cleaning. One more, just so we've really got these under control. If a member requires assistance with learning how to routinely make their bed, vacuum their room, and take out the trash, and the member also experiences respiratory issues that require regular air duct cleaning to maintain their safe living environment, what are the appropriate services? Oh, you guys are too quick for me today. I couldn't even finish reading that question and you got it. It's homemaker and extraordinary cleaning together. And a reminder, this person's 27. They would be on the SLS waiver if they're getting both of those services. All right, another term that we need to discuss when we talk about homemaking is legally responsible person. This is another term you should be familiar with. We haven't changed it, but we've helped you understand it a little bit more here. This came out with Community First Choice. Legally responsible person means any person who has a legal responsibility to care for another person. For children, this includes the parent or the legal guardian of a minor child. For adults, this is limited to the member's spouse by marriage or common law marriage, and it does not include the parent or legal guardian of an adult. We have updated the legally responsible person guide, and it lists out the requirements and all of this information. We've tried to make sure that that's a useful guide for you. It's available on our case management tools webpage for you to access. A reminder here, legally responsible person hours are part of the total of homemaker hours. They are not in addition to. In the same way that protective oversight is not in addition to personal care, but it is a component of. LRP does not include hours that are authorized under extraordinary cleaning. That is a service that's offered through the CES and SLS waivers only. For homemaker and LRP, we do have new limits. The new annual limit on homemaker is 4,500 units, which translates to about 3 hours a day. The new limit for legally responsible person for homemaker is 5 hours. This is down from 5 hours per week. Pardon me. This is down from 10. There is a limit of 2 legally responsible persons that can be paid caregivers for a single member. So even if that member has more than 2 LRPs, only 2 of them can be paid homemakers. These new limits are helping us to align policy. When we look at other Medicaid programs, there's often a cap on caregiver hours. And this is a quality-focused action as well as a sustainability action. Exceptions to the homemaker total limit we're going to discuss later, but I want to let you know now that there is no exception to the individual LRPs going above 5 hours. If a member has 2 LRPs providing homemaker, each LRP could provide up to 5 hours. If your direct care service calculator line is above 5, your supervisor is going to need to review and approve that for only up to 10 hours, given that that person has 2 LRPs. In the bridge system, the case manager supervisor is the only person who has the security role to authorize above that 5 hours, after which you can submit your PPA. Remember, homemaker hours are inclusive of the LRP and not in addition to. And if you authorize acquisition, maintenance, and enhancement of skills, you must also be indicating this as such in the bridge and have the corresponding goal in the care plan and service plan. Another interactive question for you guys today. Does the legally responsible person include the guardian of an adult? Again, so quick, you guys. Whales are the correct answer. The LRP does not include the guardian of an adult member. Good job. Next, we're going to move into health maintenance activities. Health maintenance activities are skilled, routine, and repetitive health-related tasks that are furnished in your member's home or in the community. And these services must be necessary for health and normal bodily function that a person with a disability is unable to physically carry out. This service is available through Community First Choice. Think for a moment here again, what are some of the tasks that are included in HMA? Okay, if you were thinking about care tasks that are related to care for the skin, the nails, mouth, dressing, feeding, toileting, exercise, transferring, all of those good things, you are correct. The key here, these are similar to personal care services, but they must have a skilled care component. So thank you for thinking about those. What is the new process that's in place for helping you decide whether to authorize personal care or HMA? Think for just a second here. If you're thinking direct care service calculator, you are correct. Remember, as of December 22nd, so just a couple of weeks ago, case managers are using the task definitions tab within the direct care service calculator on your direct care service calculator and the HMA documentation guide to support determining when a service is skilled and how to document and authorize it. And that is because we have ended our nurse assessor program that was discontinued. And now you all are utilizing those resources to do your authorization. The requirement to utilize the direct care service calculator and age appropriate task standards and regular task standards is currently in effect. We're not waiting for April for that to go into effect. It already is. You're already utilizing these task standards. So we're adding on to it now with our April 1st caps. All right, documentation requirements for HMA. This is part of what you have gotten information on already, but we have effectively identified some gaps in required HMA documentation. When there's missing or outdated documents, this limits your ability as a case manager to verify skilled care needs and to authorize services appropriately within your person-centered support plan. To address these issues, we have developed the new HMA member checklist and updated the CFC HMA documentation guide. So we've got 2 documents here, okay? Members who are self-directing their services through CDOS or IHSS must now provide you with supporting medical documentation for HMA tasks. And this is in preparation of their level of care screen. So you as case managers can collect and retain this information in the member's record of the CCM. The member checklist should be provided to members in anticipation of their annual assessment or their initial assessment. This checklist outlines the kinds of medical documentation that will be required and from whom it can be received from. These are not self-reported diagnoses, but rather medical documentation that's dated and from a medical professional. Documentation, in order to authorize HMA services, has to be current. And when we say current, what we mean is within the last year for children and within the last 3 years for adults. Members and case managers can use both the CFC HMA documentation guide and the HMA documentation checklist as part of your regular intake, enrollment, and annual assessment person-centered support planning processes. These tools are intended to strengthen consistency, accuracy, and transparency across all assessments and authorizations statewide. Documentation should always be uploaded into the member record in the Document Center under Medical Care Related Attachment in the CCM. You'll follow the naming convention, first name, underscore last name, underscore document name, underscore date. In the event that you are not able to receive supporting documentation or cannot see support by recent or relevant documentation, then you must not approve HMA as a task. However, you may be able to approve some personal care if it's applicable. So when are these documentation requirements effective? Immediately. They're actually already in place. There was a policy memo that was released out just a little while ago. I think that it came out maybe on January 5th, so you should have seen that. If you haven't, go check it out on our memo series. What this says is that for new members without previously authorized health maintenance activities, documentation has to be provided and obtained before any HMA can be authorized. For members with current HMA services, your service authorization can remain valid until the last day of their certification period or until you're doing a revision resulting from a change in service needs or something else is requested, whichever one of those occurs first. Existing services can be carried over into the new certification period for prior authorizations for up to 30 calendar days while you're waiting for that HMA documentation to be obtained if they never had to provide that before. For any new HMA services requested as part of a revision, all of your documentation has to be provided to you before you can authorize. If documentation to support the HMA task fails to meet the task standards necessary or the standards necessary for determining or supporting HMA, then you have to complete your long-term care notice of action for a denial or reduction in services. It's so, so important, guys, that we get this documentation. We've got those checklists for you and that documentation guide to help you along in this process. As a reminder, here, when you're assessing someone for HMA services, for health maintenance activities, you need to make sure that you're also inquiring with them about any long-term home health or private duty nursing services that they may be receiving. Make sure that you're asking members if they're receiving services from another agency. If they have a nurse or a licensed professional coming into their home, they may or may not know it's called a home health agency. You want to work with them to see if you can get the contact information for that agency so you can do some coordination with the agency and ensure that there's no duplication of services from what you're intending to authorize under personal care, homemaker, and HMA with what they might already have going on under long-term home health or private duty nursing or other skilled care. Go ahead and attempt to contact that agency. Maybe you get their 485. Do your best here to get this information because we want to ensure that you're not authorizing services in a duplicative manner. There are new limits here for health maintenance effective April 1st. All of these new limits, these limits I'm showing you are effective for April 1st, 2026. The new limit here is 19,000 units, which translates to about 13 hours a day. Exceptions, again, to all of these units, we're going to cover here in a little bit in the training, but this is that new limit. All right, let's see if you're sticking with me here. How often do you need updated documentation for HMA services? Choose your emoji now. Okay, I think I saw some of you switch your answers maybe, but turtle is coming across to the screen, and that is correct. Both rabbit and whale. This one was giving you a little bit of things to think about here with the emojis. It's 1 year for children and 3 years for adults. Okay, next up, I want to reference back to a page that hopefully you are familiar with, but resources can be found on the HCPF Case Manager's Tools page when you scroll down to Program and Waiver Specific Resources. There are several tools to help you with authorizing and documenting these services. There are 2 direct care service calculators, one for adults and one for children. That's what's highlighted on your screen here, but there's going to be lots of other resources on this page too. So I encourage you to bookmark this page, flag it, keep it handy. We want you to be accessing services from the website so you have the most updated version. And we'll discuss more about some of these resources and processes later on in the training. Also, additional information can be found in our memo series. All right, we're going to review. This is the first chart that we showed you today, a summary of the limits for personal care, homemaker, and health maintenance activities. We've got 10,000 units, 4,500 units, and 19,000 units as annual limits for these new for these tasks under these new limits. These are approximate daily hours, 6.5, 3, and 13 hours a day. So we're looking at quite a lot of hours if we were totaling all of these up. We'll be discussing exceptions to these limits here in the next section. But let's pause for a minute. I'm going to check to see if we're at a good place in our Q&A, no tech problems. Let me take a look here.
No tech concerns. We have questions coming in.
And we can get the link for that case management tools page into the chat for you guys, for sure. I saw some questions there about that. I encourage you to take a look at those HMA documentation guide and the HMA checklist. I do see some questions in the chat here wondering about providers and provider responsibilities. I just want to let you guys know that the department is doing some provider training as well regarding these caps and requirements. So that's in the works and coming soon for those providers. They'll also have the availability to access all of the same documents that you have available to you as well. I see that we've got some subject matter experts working in the background to address some of the answers from your questions coming into the chat. So I will let them keep working on those. We appreciate your questions coming in. And we're going to move on to our exceptions process. This is a key component of the caps that have been explained here. And I think it will help put some of the pieces together for you on these new authorization limits. So far, we've discussed the limits on personal care, homemaker, and HMA. And these are the numbers that you see on your screen in yellow. That's what we were just showing you. You can see up to 10,000, 4,500, and 19,000 in that middle column there. You'll notice that there's a green column here too that's below those limits. You might be thinking, why? I thought the limit was 10,000. It is, but as a case manager, you can authorize services below the caps. Supervisors are going to have to sign off and approve and authorize authorizations that fall within that yellow column and up to the cap, and for individual tasks that go above the task standard. So really this range that you're seeing here in yellow is when you're going over a task standard on your direct care service calculator, it's likely putting the service up into that range where you're going to need a supervisor approval in order to move forward. You already may be thinking about members on your caseload that exceed these limits. Because these limits are considered soft caps, there's going to be a process by which you can request to authorize over the limits. These requests are going to be submitted to the state for review and approval. The first column here lists the service benefit. Notice that protective oversight is within personal care, remember? And it's not in addition to the cap. You'll also notice that there is no supervisor review for protective oversight. If you are requesting to authorize more than that 7-hour cap, then that will need to go for state approval. One more thing to notice is that legally responsible person cap is again within homemaker. It is not in addition to the cap. So we're not adding those hours on to the cap. It has to be a component of that service. And again, there is no exception to go above that 5 hours per LRP for that component. Again, that second column is green. It lists the caps and limits that you as a case manager can authorize with no additional process or check to your authorization. Most members are going to fall into this category. The third column gives you the caps and limits that will need your supervisor to sign off on. These are full caps that we just discussed. When you need to authorize above that cap, above your task standard, you'll need not only the supervisor approval and sign off, but also a submission to the department if you're going to get up into that higher range above 10,000, above 7 hours, above 4,500, and above the 19,000 annual limits. Notice here as well that the hours are listed per week. In previous slides, we were giving you that estimate per day, what that would look like, just to give you context of what that means when we're translating units to hours, to days, to weeks. Here they are listed in weeks, and that's going to help you align a little bit better with your PAR. We're going to look closer at the exceptions process now and how the direct care service calculator can inform you about which step you need to take. We'll revisit this table later once we've discussed the process. Before we go into step-by-steps for the exceptions process, it is so important we talk a little bit about extraordinary care and parental responsibility. Extraordinary care is a standard that applies across all direct care services. When a service is provided by a family member, it must meet the definition of extraordinary care, regardless of the specific service type. The key consideration here is whether or not the care exceeds what a family member would ordinarily provide to a person of the same age without a disability or chronic illness, and whether it's necessary to ensure the member's health and welfare and prevent institutionalization. Extraordinary care applies when the care exceeds what a family member would typically provide. It's necessary for health and welfare and to prevent institutionalization. I'll give you an example. Maybe a parent is providing daily tube feedings, sectioning, and seizure monitoring for a 6-year-old child with complex health medical needs. These tasks exceed what a parent would ordinarily provide to a child of the same age without a disability, and they're necessary to maintain the child's health and prevent hospitalization. Because these services exceed typical parental care and are medically necessary, they do meet the definition of extraordinary care, and services may be authorized when provided by the family member. Remember, parental or legal guardian responsibility means the legal rights and duties held by a parent or court-appointed guardian to provide for the well-being of a child. To provide for the physical, emotional, developmental, and functional well-being of a child under 18. This includes the responsibility to assist with or oversee activities of daily living and instrumental activities of daily living that are necessary for the child's development. When determining service needs for children, case managers must distinguish between care that is typical for a child of the same age and care that exceeds age-appropriate expectations. Only supports that rise above normal developmental caregiving meet the definition of extraordinary care and may be authorized. It's so important to keep these things and these definitions in mind when you're going through your authorization process, and particularly important when you're going to ask for an exception to any of the limits that we've provided. So with the exceptions process, the direct care service calculator contains functionality to alert you as the case manager when you have to request an exception, and it also includes additional operational instructions. So please read through those instructions when you're filling out your direct care service calculator. When completing the direct care service calculator, the fields are formatted to turn yellow or to turn red when action is needed. The cells will turn yellow when the hours that have been entered are above the maximum task standard. This is when you're going to need to get your supervisor involved. Cells will turn red when the total service hours or task hours for protective oversight, because we have a little bit of an outlier there, are over the service thresholds. We're going to take a closer look at the supervisor review first. Remember, you as an individual case manager cannot authorize above the task standard for a particular service. Your supervisor needs to complete a review and approval before you can finish your PAR. First, you as the case manager will enter your justification on the direct care service calculator for any task standards that have turned yellow. Then your supervisor or an alternative qualified professional will review for approval or denial and sign your direct care service calculator. If your supervisor did not approve, you will need to adjust your DCSC to authorize fewer hours. If this is a reduction or a denial in services, you'll be sending a notice of action. Always upload your DCSC to the CCM. Supervisors will review requests based on the following criteria. Is the care documented? Is it extraordinary care? Is it age appropriate? Is it duplicative? And is it necessary to prevent institutionalization? If all of your total service units were below the total annual units and your supervisor did approve any task standards that were above, then you're good to go and you can complete your service planning process. If any of the boxes in your direct care service calculator have turned red, you must move on to the state review level. Task level boxes will turn yellow with the exception of protective oversight, which will turn red along with any service level total box if over the limits. You'll be able to submit state level reviews through the state review Google form, which will be located on the long-term services and supports case management forms and tools page. If you need to have a state level review, you must first have completed all of the steps for a supervisor review, including signature. All necessary documentation should be uploaded into the CCM prior to submitting an exceptions request to HCPF. The boxes in the direct care service calculator will turn red if the state review is required. You must submit this request at least 30 days in advance of your member's effective start date, service effective date. For CSRs, This is going to be 30 days prior to their certification end date. That doesn't mean you need to wait until the 30th day. It just means that you can't do it after that, right? We need enough time for submission to make sure we can get all of the information we need for an approval. Ensuring that you meet this timeline will prevent a gap in service coverage for your member. HCPF is going to have 14 days to review your request. When you submit, if you're providing all of the necessary documentation and justification for the request, this can eliminate the need for HCPF to ask for additional information. And it could result in a lapse in coverage if you're not able to provide and submit timely. You will get a decision by email from HCPF, and you must document this in the care and case management system. If the request is denied, the member should be sent the Medicaid Sustainability's Notice of Action, which we'll cover a little bit later in this training. This will afford the member appeal rights. The member is not appealing the exceptions process, but rather the reduction or denial of services based on the governor's required Medicaid sustainability actions. Again, the Google review form to submit exceptions will be posted on the Case Management Tools webpage. There are several considerations that you should keep in mind during the exceptions process. Remember, you do not always need to submit an exception prior to denying or reducing services. If the member wants to keep or increase services, but you as the case manager do not agree based on your assessed need, on the documentation that you've received, on the service definition and task standards, then you can just send your notice of action, allowing the member to have their appeal rights and go through the ALJ process. Again, we'll talk more about that later in this training. As a case manager, you should always be thinking about what is a typical parental responsibility versus what is extraordinary care. And if you do not have the appropriate documentation or the ask does not align with the assessed need or service definitions, which includes inclusions and exclusions, and your knowledge of the member's needs, you, again, do not have to submit an exception to the department. You can issue out those reductions and denials based on the supporting documentations that you already have. Remember, the department's exceptions are completed when the entire service is over the cap and for limited specific tasks like protective oversight. Consider always if the task is medically necessary to prevent institutionalization. Keep in mind the questions that your supervisor is going to be working through for their level of review always when you're doing service authorization. This is going to help the process go a lot smoother. If members' previously authorized services decreased based on the new direct care service calculator, but they're below the cap and the task standards, then no exceptions process is needed. Again, you can send your notice of action at that time. All right, another little summary slide for you of our actions for you as case managers. To summarize what we've just gone over, these are high-level actions you take as a case manager. During the next continued stay review or regularly scheduled monitoring that you have with your members, utilizing personal care, homemaker, and HMA. First, you'll be determining if they are authorized above any of the limits. After completing the new direct care service calculator, determine if an exceptions is required and complete one if it's necessary. After that, you can complete your service reduction or authorization when appropriate, and proration might occur during this time if you're doing this at a monitoring visit rather than a continued stay review. More specifically, at a continued stay review, you guys are conducting new assessments using your age-appropriate guidelines when needed for children. You're going to use the revised direct care service calculator to authorize personal care, homemaker, and HMA services, and you cannot authorize services above the new limits without the appropriate level of approval. At a monitoring visit, if the member's receiving any of those services above the annual service caps, you are going to be needing to complete a new updated direct care service calculator to determine appropriate service authorization, reduce the services in their service plan and care plan to below the service caps, or submit an exceptions request when appropriate. You'll be following your existing process to revise services in the bridge, and the system will auto prorate units on the PAR based on the time left in the next until the next annual assessment. Next, one more interactive question for this section. The personal care, homemaker, and HMA exceptions process for state approval should be completed when? Choose your emojis now. All right, I think you guys are getting it. That's correct, Whale. You can complete this when there is an exceptional need for care that is thoroughly documented and above the respective caps. All right, I'm going to take 1 second to pause here and see how we're doing in our chat. Looks like we've got lots of questions answered already, a couple more that are in the works. We do appreciate those questions coming in. Remember, task standards have been out and applicable and in regulations for a little while now that says you're required to use those task standards. So if you're working on cases that have start dates before 4/1, that is still applicable for you to be able to utilize and use as justification for a reduction or denial. What we're talking about here today is the implementation of these caps at 4/1 start dates going forward. All right, let's move on to our next section. We're going to be talking about caps on caregivers. So in addition to the 5-hour LRP for homemaker cap for caregivers, there is now also an overall cap for caregivers that applies across multiple services. We have implemented a weekly limit of 56 hours per caregiver for a single member. This limit is for the total hours across personal care, homemaker, health maintenance activities, long-term home health aides, and long-term home health nursing services per member. The 16-hour per day limit for caregivers across all services and members served is remaining. So that's not changing. We've had that for a little while since CFC has gone into effect. We now have this 56-hour a week limit. A caregiver may work up to 56 hours a week per member. Additionally, each caregiver may work up to that 16 hours per day total for any number of members that they are caring for. A caregiver can work more than 56 hours in a week if they're providing care to multiple members, so long as they do not exceed 56 hours per week per client or that 16 hours per day total. What this means is that there's a limit on the number of paid caregiving hours someone can provide each week. This doesn't mean that you need to reduce your members' authorized hours, but it does mean that you will need to speak with your member about caregivers they have and make sure that they understand and are aware of the new limits. If their caregivers are above the weekly limit, work will need to be done with the provider to identify additional caregivers who can provide support. If the member is using IHSS or traditional agency care, the agency is responsible to help them find additional caregivers. If the agency is unable to recruit additional staff, members and families may consider using CDOS. Under CDOS, members and authorized representatives are responsible for recruiting all staff. However, more of their allocated resources are available for caregiver wages, often making recruitment of caregivers more successful. If a member needs more than 56 hours per week of services, members should work with their agencies and employers to recruit additional caregivers. You can send members to Direct Care Careers, which is a free national job platform that's designed to connect direct care workers with employment opportunities. It's a smart job matching tool that pairs qualified workers with employers. In addition, you can also have members access that are self-directing access information and assistance through Consumer Directive Colorado. That's another free resource that can help support members and their authorized representatives with employment needs. There is no exception for children or adults to this limit. In rare emergency cases, a cap could be exceeded temporarily, but there's no way to request an exception ahead of time to go over this limit. Members needing care beyond 56 hours per week can receive paid care up to their authorized amounts, just as long as it's provided by multiple caregivers. As a case manager, again, your responsibility is to discuss with your member the upcoming change to the caregiver limit on specified services. If needed, work with the member to identify alternative caregivers to fulfill the authorized hours. Case managers do not need to make any changes to the support plan or the PAR if a single caregiver is providing above 56 hours per week of care to a single member, or above the 16 hours per day across all of their members. There is a provider agency responsibility to ensure they are not going above the limits. If the member's caregiver is over the limit and they do not intend to find an alternative provider, you must document this in the care and case management system as an activity log. You should not reduce service authorization for this reason, and therefore you will also not send a notice of action. Caregiver caps will not initiate that notice of action or appeal rights for members because we are not reducing their service authorization. We are just asking them to not have it provided all by the same caregiver to exceed those caps. Small example, the member is receiving up to the service limits for homemaker personal care and health maintenance. That would total 160.25 hours a week, or almost 23 hours a day of care. Only 56 of these authorized hours can be provided by one single caregiver, meaning the member will need additional caregivers to provide the remaining 104.25 hours. Again, that 16-hour-a-day limit still applies. And so if somebody was working 16-hour days, they would only really be able to work 3.5 days out of that week to make sure they were staying within those caps. All right, we're going to switch gears a little bit and move into the new age limit and cap for Community Connector. Another service that you should be familiar with is Community Connector. These services are available on the CES and the CHIRP waiver. These are highly specific, purpose-driven services intended to support one-to-one community integration for members who are age 6 and older and who have an exceptional need that exceeds age-typical parental or legal guardian responsibilities. They are provided to a single child who is in need of extra support to connect with, meaningfully and actively participate in, and use community resources. Paid supports for this service are actively providing support throughout the activity. Services must be provided one-on-one. If other children are present during an activity, another parent or responsible person must be present to supervise those children. The purpose of these services are to support community integration and independent participation through relationship building, skill development in community settings, and delivery under a person-centered service plan. It's key to remember that in addition to Community Connector services being an active part of group activities, the service also requires it be above and beyond what the responsibility of a parent would normally be. You can take a look at the bullets on your screen to see a little bit more about what Community Connector is covering. We'll talk more in a few slides. There are new age limits for Community Connector. You may have heard me say that in the last one, 6 and above. There is now this limit. No one under 6 years old can access this service. It is really only for school-aged children, 6 and up, with an assessed exceptional need. For children under age 6, Accessing and engaging with the community are considered typical parental responsibilities. And so this age limit is going to be in effect for everyone that it applies to beginning April 1st, 2026. What that means is that case managers will have a conversation with the member, update their service plan to end the service, and send all notice of actions to affected members by March 15th. Case managers can end date the PAR at this time and notify the provider of the service ending. It's important to know, though, that HCPF will auto end date PARs for children who are under 6 years old on April 1st, in case that has not happened for someone. And at that time, any billing will be denied. There is no exceptions process to request services for a member under age 6. For children who are over age 6, we do have some new limits as well that are effective April 1st. The annual limit on Community Connector is now 1,040 annual units. This is a reduction by half from the previously allowable amount. The 1,040 limit is not a given for each child. Authorizations for this service must be based on assessed exceptional need in your level of care and through age-appropriate guidelines, must be clearly documented in goals and strategies in the person-centered support plan. It must have appropriate community activities that involve active, meaningful participation, and reasonable units that are tied to a specific activity, not just for convenience or availability. For example, a 6-year-old needing help with safety is a typical parental responsibility. A 15-year-old who needs significant safety support may represent an exceptional need. Age matters with this service so much. Community Connector services must be conducted in a variety of settings in which the member interacts with persons without disabilities. For children over 6 years of age, here's a list of appropriate activities. The list is not all-inclusive, but we did want to give you a couple of examples for a couple different age groups for this service. While community activities are often not free, this service does not cover the cost of these activities. What that means is that if a request for units is simply to pay for tickets or admission fees or equipment or costumes, you will not be able to authorize units for expenses incurred. What would be included is the support personnel that are helping the member meaningfully participate in that community activity. Here is another list of activities that are provided if they are done so exclusively for recreational purposes, as well as having a passive presence in the community, then they are not a benefit of this service. Examples of these activities that are excluded might be things like solo or family walks, fishing alone, to a park alone. For example, ensuring the safety of a child in a parking lot or near roads by making sure they look both ways before crossing really is a typical task of a parent of a young child, and it shouldn't be the reason to authorize services. Driving or taking a child to sporting events on the weekends or evenings is also considered a typical parental responsibility. And even encouraging children to participate in sports, etc., are considered normal parental responsibilities. Remember, this service is not a default service. It's not entertainment. It's not just for supervision. It's not a substitute for other waiver or state plan services, and it is not automatically authorized at the maximum. It does not replace parental responsibility, and it cannot pay for services during normal school hours. There are exceptions to this new annual limit, that 1,040 limit. Exceptions requests are only for members who receive Community Connector services and require an increase in frequency or duration of those services. An exceptions request can be made to the department by the case manager, but must be made again at least 30 days before the member's certification end date and prior to PAR authorizations. You can submit requests using that same Google form on the case management tools page. And requests must contain detailed information about why the additional units are needed. Examples of some of the questions that you'll see on the exceptions form include things like, describe what this member's schedule looks like. Explain what goals the member is working on through the community activities. Include the schedule of activities. How do the activities participated in go above and beyond parental responsibility? Describe the exceptional need of this member. HCPF will have 14 days to respond to your exceptions request in the original submission, and they may request additional information. Decisions will be emailed to the submitting case manager and should be documented in the care and case management system. Exceptions requests could be denied if the services requested do not meet the intent of Community Connector, if they fall short of the service purpose, or requested services have limited community engagement beyond paid supports or are for segregated activities. Remember, you do not always have to submit an exceptions request. If it is determined by you as the case manager that the request for services does not fall within the service description, or you are unable to justify the need through your age-appropriate assessment and documentation, you can reduce authorized units to the new 1,040 limit and send a notice of action. Let's look at an example of an appropriate Community Connector exceptions request. Pardon me there, guys. This is Aaron. Aaron is 12 years of age. He's on the CES waiver. His mom would like him to be able to increase his danger and safety awareness. He wanders all of the time. He runs away from her in the hallways, on the stairs. He needs to have his hand held for safety while they're out in the community, but he'll still try to pull away from her. Sometimes he sits on the floor and refuses to leave when they need to go. His mom tries to get him in the car by carrying him, but he scratches, hits, and bites her. He's unable to communicate his wants and needs, and he cannot tell you his name or address. He's wandered and become lost in the past and could not communicate who is lost or in trouble. He does not comprehend the concept of strangers and does not communicate if he's hurt. He's tried to open the car door many times and the window while the car was driving. The 1,040 annual limitation is really not sufficient here to meet Aaron's needs due to his high needs for supervision in the community and his family's challenges to find caregivers that can ensure Aaron's safety both at home and in the community. He likely needs about 1,500 units of Community Connector services as provided by his mother. Community activities include weekly trips to his buddy reading program at the library, weekly community art classes, and weekly volunteering as a junior park ranger, all places where he can be actively interacting with community members. He needs assistance with all of his prompts and physical redirection to ensure safety of himself, property, and others. And at 12, this is beyond what's age appropriate for a 12-year-old. So, for the exceptions process, the case manager will evaluate all other available services to ensure his needs are fully supported, confirm whether or not he has EPSDT, and if not, explore EPSDT. Determine whether the supports required go beyond typical parenting responsibilities, and again, in this scenario, they do. The case manager should assess whether respite or other services would be a more appropriate service for certain activities. Then, once all appropriate services are being utilized, the case manager can submit the exceptions form to the department, providing detailed responses clearly and explaining why his needs reflect extraordinary care and support. Ensuring full detail will help eliminate delays in receiving decisions from the department. The request can be reviewed for approval or denial, and then you'll be able to proceed accordingly with your results to authorize the PAR. We're going to talk a little bit about proration guidelines here for Community Connector. It's a little bit different than the personal care, homemaker, and HMA proration. We don't have the bridge to automatically prorate for you. Proration guidelines are for members who are completing a service plan revision at their next monitoring visit, right? We're looking at shortening up their authorized hours, not for that full certification. These members would not be having their continued stay review assessment completed by September for that December start date. So this is for your monitoring visit revisions. You'll be required to reduce the members' PAR down to the new annual limit of 1,040 units. If units remain available for use and no additional units are needed after the service plan reduction to 1,040, then you can send a notice of action and no further action is required. If units do not remain or the member requests above 1,040, the case manager must submit an exceptions request. Exceptions will be limited to a maximum of 52 units per month for the remainder of the service plan year. This is a prorated amount of 5% of the new cap. If an exception is denied, you must send the Medicaid Sustainability Notice of Action for those cases. Since they're done at your monitoring and not your continued stay review, you must indicate an effective date of 60 days from the date of the monitoring visit, or April 1st if your monitoring is done prior to that. This gives members and their families and their providers ample time to make adjustments to meet the changes required within their service plan. Again, that effective date, 60 days from the date that you completed your monitoring, should be reflected on the PAR and on the notice of action letters as appropriate. We'll look at an example where the exceptions request would be prorated for the remainder of the service plan year. Gabriella is 9 years old. Her annual assessment is in December of 2026. She was previously authorized at 2,080 units of Community Connector benefit per year, which is now over the new limit. At her monitoring meeting in April of 2026, Gabriella used only 300 of her 2,080 units authorized from the previous year. Gabriella has an assessed need for Community Connector because she participates in community gardening assistance, but she actually doesn't need more than 1,040 for the full year. Here's what the math looks like. Now think, as a case manager looking through this math that we just talked about, what would the appropriate action be for you to take here? Okay, if you said reduce her limits to 1,040 for the remainder of the year, you are correct, right? That's the action we're taking here to reduce down to that limit. We'll look at one more example here. This is Johnny. Johnny is 16 years old. His annual assessment is in November of 2026, which means his reduction needs need to occur sooner than his continued stay review, and it's going to be at his monitoring. He was previously authorized 2,080 units of the service, and at his monitoring, he has used 1,000 of the units authorized. He has an assessed need for Community Connector. He does community enrichment classes and likes to volunteer. He's going to need more than 40 units to continue for the rest of the year. Here's what the math looks like for this one, a little bit more complicated. But think a little bit here. What action would you take for Johnny? All right. If you said submit an exceptions request, you're absolutely correct. We're going to submit an exceptions request to the department for Johnny for 6 times 52, 52 units a month for the remainder of his service plan year, which is 6 more months. We're going to subtract out the 40 units that he has remaining before we do this change, and ask the department to authorize that exception at the prorated rate. Okay, high level here, summing it up for you. Actions for case managers during your next regularly scheduled monitoring or continued stay review that you have with your members utilizing Community Connector. You're going to assess or review the member using your age-appropriate guidelines and the Community Connector Services Guide that's on our department website. You're only going to have hours authorized that are based on their assessed exceptional need and the time required for their authorized activities. And you should have documented appropriately the goals and objectives in their care plan service plan section of the CCM. If they have more than the new limit of 1,040 units authorized, there must be a reduction of services, or you must submit an exceptions request to the department for not more than 52 units per month, minus any unused units under the 1,040 cap. Another question, see if you're with me here. Community connectors should be authorized for children age 6 and above when? Choose your emoji now. All right. I see those turtles coming across the screen. You're correct. It's all of the above. It's so important for this service to make sure that we have an assessed exceptional need, that it's clearly documented in goals, it's appropriate community activities that are meaningful, and that the units being authorized and requested are reasonable and tied to specific activities. The Community Connector Service Guide, again, it is located on the LTSS training page for you to access. It has been updated, revised, refreshed. It has a ton of information, and the expectation is that you're utilizing this guide when you are authorizing this service, and especially so when you are going to submit an exceptions request if that's necessary. We have a short pause here. I think we can take another look at the Q&A before we move on to giving you that chart again one more time. Let's check the Q&A here a bit. Okay, I do see lots of questions in there having been answered. You guys are asking wonderful questions today. I think you're really paying attention and thinking hard about these. I appreciate that. I do want to remind you guys about your own responsibility to relay these changes to case managers. There's a lot of changes coming. And the department has put out communication about them. But as a case manager, we are also looking to you to explain these changes to your individual members. We have provided fact sheets for you on each of these services, an operations guide that also has additional resources in it to help you move through those conversations. We're going to talk a little bit about that today as well. But we do look to you as the case manager who has a relationship with your member to be communicating some of this information to the members that it's impactful to. All right. We're gonna move on from the question slide, although I am thankful for all of our SMEs in the chat there answering questions. Again, remember, if we don't get to everything, we have office hours for you guys to come to in the following weeks, and we'll also have some FAQs coming out. This chart here hopefully looks familiar to you. As promised, I said we would look at it again. This is the full chart of the new authorization limits for personal care, protective oversight, homemaker, legally responsible person, health maintenance activities, and community connector, all in one, all on the same chart for you. Some of these limits have an exceptions process, while others do not, right? We said you cannot have an exceptions process to authorize Community Connector for people below age 6. There is no exceptions process to the 5-hour limit for LRP. In the next slides, we're going to move to talking about changes for IRSS. And that chart that we showed, it will be available for you as a resource as well. IRSS services individual residential benefit that is available exclusively in the HCBS DD waiver. The DD waiver provides access to 24-hour supports and supervision. The service uses a variety of living arrangements to meet the unique needs and support and guidance of habilitation for each member. Residential habilitation services and supports help members stay safe and healthy in their home and teach skills needed to live in the community. Services are very comprehensive, include things anywhere from assessment and evaluation, training, transportation, all the way to behavioral therapy, therapeutic interventions, medical and healthcare services, travel, and supervision. Currently, IRSS settings include host homes, family homes, member homes, and staffed homes. Excuse me. Give you a little background here on this IRSS rate alignment. This is effective 4/1/2026 and forward. The way IRSS settings are defined in regulations has been a little unclear and does not account for the variety of settings that are available to members who are receiving the IRSS. Further, there are 2 rates for IRSS, and it has been a little bit confusing on which rate each setting should use. HCPF is clarifying definitions for each of these settings and the 2 existing rates that apply. Again, there are 2 rates. One rate is for people who live in the home of a person who is taking care of the member. Sometimes this is family, and sometimes it is not. That is known as a host home with a specific host home rate. The second rate is for a member who lives in their own home or the home of a provider, and caregivers come in and out to provide care. This is known as a staffed home rate. Because of the administrative costs of running a staffed home, it is more expensive, so the rate is higher. Workers are not at home, and so they must be paid hourly. HCPF does not pay based on whether or not the caregiver is related to the member, but rather based on the kind of service. In Colorado, there's actually no such thing as a family caregiver rate. Members can either use family caregivers or non-family caregivers or a mix for either service. This action that we're taking here actually is aiming to align billing practices and ensure that providers are using the correct existing rates. There are no new changes to how host homes will be monitored. The existing expectations for oversight, documentation, and provider involvement are all still the same. Let's look a little bit closer at the 2 settings on the next slide. IRSS staffed home, that's the higher rate. It's a setting in which IRSS supports are provided by the residential agency staff who do not serve as the primary caregiver. Care in a staffed home must be managed by the provider agency. Remember, a family member can be staff if they do not live there full-time. This is because these are typically agency staffed and cost more to operate, so they're going to have a higher rate. Shared living environments means a setting in which the IRSS supports are provided to the member by an individual who is acting as the primary caregiver for the member. A primary caregiver is a caregiver who personally provides, on average, at least 51% of the total IRSS supports to the member and resides in the same residence with the member. The setting must be occupied by the individual providing care at least 75% of the time. A host home is considered a residence type under the IRSS shared living environment setting. The rationale for this is that the model has lower staffing costs because the caregiver lives in the home. Next, we'll provide a high-level overview of the case manager and provider responsibilities. For case managers, during the next regularly scheduled monitoring or continued stay review that you have with your member who is in an IRSS setting, you need to determine if they are in a shared living environment or a staffed home setting by working with the provider. You'll need to adjust the PAR to ensure that it reflects the correct setting rate. For some members, it might. For some members, it might not. You will not be completing a service plan revision or a notice of action. These are not service reductions or denials, but rather a change to the provider rate to ensure that it aligns with the appropriate setting definition. There are actions for providers too. Provider agencies are going to be required to perform the following actions for members who are in their IRSS settings. They will be asked to categorize each member's IRS setting according to the updated definitions, staffed home versus shared living environment, notify you as the case manager in writing within 5 business days of any changes to the setting type that require authorization updates, and maintain the documentation needed to demonstrate their compliance with service delivery records, residency verification for primary care providers, payroll, all of their same responsibilities that they have now. They're also being informed that failure to comply could result in recategorization of their setting type or corrective action plan. Provider agencies are going to continue to demonstrate compliance with all of their same billing requirements that they have outlined in regulation. Case managers should check with providers to get this information if it's not been provided to you at the time of your CSR monitoring. Let's look at the table of rates and name changes to show you those updates in context here. All IRSS 2016 procedure codes inside and outside of Denver are going to have updates to their naming conventions. IRSS rates and services are not changing as a result of this alignment. The name updates will reflect the naming conventions from this alignment, including staffed homes and shared living environments. So you can see what it is right now and what it will be for these changes. As a reminder, no changes have been made to the group residential services and supports rates, naming conventions, or services. This only applies to IRSS settings. All right, a member lives in a home where the primary caregiver lives in the home as well and provides more than 51% of the member's care. Under the updated IRSS naming conventions, how should this setting be identified? All right, I see a couple coming. Tigers coming in. Good job, you guys. You're correct. That would be considered a shared living environment under the naming conventions. All right, we are moving right along. We're getting to the notice of action and appeals section. There is a unique notice of action for the caps that are getting implemented for April 1st forward. And you've heard me say this a couple times in the training today. I've said Medicaid Sustainability Notice of Action. This is a separate and unique notice of action that is different than the current notice of actions that you have. In order to assist you guys with this process and make it abundantly clear when you're taking actions based on these Medicaid sustainability actions, we have created this separate notice of action called Medicaid Sustainability NOA. This is the NOA that you'll be sending to members regarding the executive orders that have been put forth for us to be able to complete these actions for April 1st forward. This includes annual units on personal care, homemaker, and HMA, community connector unit reductions, and community connector age-based requirements. Some of the differences in this NOA include us citing regulatory guidelines plus the executive order that has been put down for us to complete these actions. That will include language that states we are having orders by the we have executive orders directing the state agencies to reduce program expenditures due to insufficient revenues. As a result, service limits have been revised statewide and must be reflected in the person-centered service plan. It'll also include language like Case management agencies must revise person-centered support plans to comply with current program requirements and service definitions and statewide service limits. And so you must issue a long-term care notice of action when services are reduced. When these notice of actions are sent regarding reductions or denials that are directly as a result of the executive order, this will allow you as the case manager to begin sending those notice of actions immediately for 4/1 effective dates forward, while we're waiting for more formal rules to be approved through the Medical Services Board. It also allows the notice of action to be very clear in explaining why the change was made, to help assist you, the member, and the ALJ. The notice of action can be accessed on the HCPF tools page by the conclusion of our training. You shouldn't be taking these actions until you've gone through both of the trainings. And also keep in mind, these would be not dated prior to 4/1. Couple things are not changing. Things that are not changing are your access to and expectation to utilize your current notice of actions. That includes your long-term care application status NOA, the long-term care developmental disabilities waiver waiting list NOA, and the long-term care benefit status NOA. You can still and should still be utilizing the long-term care benefit status NOA. For any application of regulation that requires you to deny services. And that could be something like the member or applicant requesting services that they do not qualify for, that are considered duplicative, that do not meet the definition, do not meet extraordinary care or service definitions and standards. We're going to take a look at a chart that shows you when you should send your typical notice of action of benefit status and or the Medicaid Sustainability notice of action. So for these actions that we have discussed here today, case managers are going to be having to choose between sending either the benefit status notice of action or the Medicaid Sustainability notice of action. The chart lets you know which one of those you should send in which circumstance. If you're denying based on assessed need or standard benefit definitions, then you'll be utilizing your regular benefit status notice of action. If you are denying due to the unit limit or an exceptions denial, you had to engage in that exceptions process or just because there is this limit, then you will be needing to utilize your Medicaid Sustainability notice of action. Really handy chart here for you to reference during these process in case you forget which one to send for which reason. Remember, caregiver limits, legally responsible person limits, and the IRSS alignment do not have an exceptions process, and you will not be sending a notice of action. They are not reductions or denials of services, but rather the need for additional caregivers to be found or alignment in setting documentation. For the changes that are made through a revision at monitoring, you have to make sure that you're indicating an effective date of 60 days from the date of your monitoring visit, or April 1st if the monitoring visit was earlier. On the notice of action, to give members and their families and providers, it has to have this 60 days to give ample time for them to make adjustments to meet the changes required within their service plan. For changes made at continued stay review, follow your normal process for NOA and timelines. You're working ahead for those CSRs, so you kind of already have that 60 days built in there. Remember, these are all not effective until April 1st or later. Changes need to be made by September 30th, 2026, 60 days prior to certification end date, in order to ensure that we're making our timelines to have these sustainability actions in place and savings realized. For changes about community connector age limit, you must send your Medicaid Sustainability notice of action no later than March 15th. HCPF provides support and appeals as we always do during the appeal process. You are able to access this support. In general, your requirements have not changed. They're outlined in your contract, and we expect you to continue to complete the same things you do now for any appeals that come through based on these Medicaid Sustainability actions. Your NOA for the Medicaid sustainability actions doesn't get dated prior to 4/1. But members do have the right to appeal and ask for continued benefits in the same way that they do now. That means that their appeal has to happen within that 10-day period of the action date. It is your responsibility to review the appeal option and process with your members and inform them of these timelines and requirements. You should always be having conversations with your members and letting them know about any reduction or denial and to expect that notice of action in the mail. If you're not able to obtain the service plan signature pages during this time, as always, you would be following suit by sending that notice of action. You need to get service plan signatures when you make changes to service plans. We will provide you support during the appeals process when it's filed. HCPF is notified of the appeal and we can provide technical assistance to you. You can reach out to that HCPF_HCBS_case management inbox to request assistance during an appeal if you need any. Here are a few examples of regulations for notices of actions. I'm not going to read them to you by word for word, but I wanted to provide you some examples here that are going to be applicable in a lot of cases. The first one is regulation about assessed need, right? If you're not meeting assessed need for a particular service, then you can move forward and reduce or deny services at your level of case management. There's another regulation on the slide here about waiver and program eligibility requirements. Remember, all service authorizations should meet regulatory definitions in rule, and you can review and cite additional regulations as needed. I always encourage you guys to be familiar with and understand regulations surrounding every service and process that you're working in. The next slide has an additional set of examples, a whole lot more here. Not all of them have the specific language, but it gives you the section you can look in. These, again, are examples of regulations that we've talked about services today, including the Direct Care Service Calculator, Community Connector, IHSS, CDOS, Extraordinary Care. Please make sure you're taking some time to familiarize yourself with what's in regulation about these services and processes. All right, a member's personal care hours are reduced because their services exceed the new statewide annual unit cap. Which notice of action is required, if any? All right, you guys are catching on fast. It's the bunny rabbit, yep, long-term care Medicaid sustainability notice of action that cites our executive order and statute is the notice of action you'll send in this situation. All right, we have a recap for you here. Again, high level, we've got about 15 minutes, I think, or so left in our training time here, maybe less. So I'm going to recap for you rather quickly, but I want to remind you, you're going to have access to a lot of resources and support to help you through these. All right, so for annual assessments and continued stay review, you've got a couple key steps here. You know, conduct your level of care screen for CSRs with start dates that are 4/1 forward. This could be at any time after you've taken both of these trainings. Use your age-appropriate guidelines for level of care screen documentation. Complete a new direct care service calculator. If the hours are calculated above caps and justified based on your documentation and your level of care screen, your direct care service calculator, align with task standards and HMA documentation if HMA is needed, you'll be submitting an exceptions request. If it's approved, you can move forward with your PAR creation, and if it's denied, you'll be moving forward to issue your notice of action for reduction of services. Any NOA for these reduction of services based on executive orders cannot be effective prior to 4/1. You'll be using the same community connector, community first choice, HCBS initial, CSR, and service planning checklists for the system, for the CCM system that are out there now. These are processes you should be familiar with that you complete on a daily basis, service plan revisions, PAR creation. If you need reference to those, you can get those in the Google Drive where our systems resources are. During your quarterly monitoring visit, for those members who aren't going to have a CSR until much later in the year, we're going to capture them at your monitoring visit by asking you to do a service plan revision. If they're receiving personal care, homemaker, or HMA above those annual service caps, you need to utilize the new direct care service calculator to determine their appropriate service authorization. Reduce their services in the service plan and care plan to below that service cap, or submit an exceptions request when appropriate. Members should not be exceeding new limits. Case managers need to follow existing processes that we have for the system to revise services in the bridge. And for these services, the system will auto prorate units on the PAR based on the time left until the next annual assessment. Members who are receiving Community Connector require a PAR update as well, and also not to exceed the new limits. Case managers can submit an exceptions request if no units remain after their reduction to the cap, and proration will be applied based on the time left until the member's next annual assessment at that 5%, which is no more than 52 units per month for the remaining service plan period. You can find additional information about this in the operations guide that has gone out, the fact sheets that have gone out, your HMA documentation guide, all of these resources that we have said, Community Connector Services Guide as well. Remember, anytime that you're making changes to a member's service plan, you must get new signatures from the member and providers. Revisions made at monitoring are required to be effective 60 days after your monitoring contact. All right, so revisions and proration, we've talked a few times about this. So I'm not going to go in too deep with examples, but you need to remember that there is this proration. So when you're entering into the PAR in the bridge for CFC services, it's going to be calculating what you have left in your service plan year for that new DCSC and the new service authorization. For Community Connector, same thing, the 52 units is the 5% of the new annual cap. We may have changes for a legally responsible person for auto proration in the future, but we don't have any information for you on that, any sort of auto proration for LRP right now. And finally, Community Connector age limits, key steps. Again, these are all effective for members on April 1st. So that means that you need to send notice of actions to your members by March 15th of 2026. Anyone under the age of 6 on April 1st is no longer able to receive this service. Notify your providers that the service is ending and auto and end date your PAR. HCPF is going to auto end date those PARs for kids that are under 6 on April 1st, and billing will not be able to happen at that time. It will be denied. Next, I'm going to give you guys some tools and resources. This page of resources, forms, and tools here is pretty comprehensive, right? We have a lot of different things out there for you. They're located on the resources, forms, and tools page. The age-appropriate guidelines, reference document to use during the 100.2, age-appropriate task standards, direct care service calculators, LRP guide, protective oversight guide, HMA documentation guide, member checklist, the exceptions form, Community Connector Services Guide, your new notice of actions, and your case manager operations guide, all out there and available for you. In addition to these other sites that are on the HCPF website memo series, very informative, benefit service and glossary, and general information about Medicaid sustainability efforts in Colorado. Again, there's also a relevant care and case management system job aids that you can access. And we encourage you to do so as you're working through the technical aspect of completing all of these changes for your members. All right, we know these are difficult conversations, so I want to give you a few tips and tricks before we leave today on these actions that are going to require difficult conversations with your members. We know that these conversations can be emotionally draining, but across the state, consistency can really build trust even when the message is hard. We encourage you at your agencies with your supervisors to debrief after difficult cases and for case managers to share what language is working well during these conversations with their peers. Here are some core skills that can help with difficult conversations. One, emotional awareness and regulation, active reflective listening, clear plain language policy translation. Try to stick away from all the jargon that I'm using with you guys today here as case managers. Collaborative problem solving and boundary setting with compassion. You know, this may feel like a loss to the member, and loss reactions like anger and grief and fear are normal and to be expected. You are not taking something away personally from them, but you are explaining a systems level change. Saying no is not the end of the conversation. Really, the goal is to understand and plan for next steps. Sometimes that next step might be an appeal. There might be other next steps to take before that. You've got to have those conversations. Clarity is kinder than ambiguity, and clear limits reduce confusion and distress over time. You don't have to convince the member that the change is good, but you do need to explain it accurately and compassionately. Here are some additional examples for you for conversation structure that you can lean into and use. Acknowledge and validate. State the change really clearly, explain the impact to your member, and name what might still be available or those next steps and support. I know these are hard, guys. These are hard conversations, hard changes to make, and they are impactful to members. But I know that these changes left in your hands as case managers are going to be done correctly and effectively across the state. Remember, the exceptions process there is to ask for exceptions above caps when it is justified. And so a straight no is never the end of the conversation. You do need to be looking at whether or not an exceptions process should be followed, whether or not we go to the appeal, all of those options we've talked about today. I really appreciate you guys being here. And our next slide, I'll just leave with you guys just a reminder of the timeline for these that we talked about at the beginning of our training here today. I know we're coming up on time and we didn't have a ton of time to do any live questions other than those interactive questions. But I know we've had quite a few questions put into the chat, and trust us that we are taking those, bringing them back, making sure we're addressing in our FAQs. And you're also able to come to office hours in the following weeks to have additional questions that are unique situations or clarification on any policy that we've provided you here today. Utilize that office hour space. We encourage you to do so. This timeline is for annual assessment. The other timeline is for the rollout at your quarterly monitoring visits. Remember, you've got any of the monitoring visit that you've got scheduled during that time before the CSRs when you can do these. We're not dictating that for you, but you need to make sure we're touching all of these cases by the end of next year. So with that, I thank you guys so much for spending your afternoon with us. We will be ending our session day 1 of the training, but we do look forward to seeing you in day 2 of this training. We're going to dive a little bit deeper into age-appropriate guidelines, the direct care service calculator, give you some examples, talk about our ADLs and scoring again. So just a little bit further into all of this information. Remember, once you've completed both of the training sessions, you can start working on this and implementing it with your members that you have CSRs for 4/1 start date forward. Thank you guys so much. Enjoy the rest of your afternoon.